Well, good evening, everyone. This is Paul Sorajja from Minneapolis, and I have the pleasure of kicking off this evening's edition of Nail It with Nadira. I'm joined here by Dr. Nadira Hamid, Edris Aman, Lynne Brown, Gagan Singh, and this is a CVI webinar hosted by our foundation, CVI. As a kind reminder, we have our annual meeting this coming July on 18th to the 20th in Denver, Colorado. This is the Operators Enclave, and we welcome you all to come to the meeting. We have plenty of ways to get you there in terms of support. Please visit our website and contact us if you're interested in participating. Webinars like tonight's will be archived as an enduring material on our website, cvinnovations.org. Without further delay, I'll turn it over to Dr. Nadira Hamid, who will kick off this meeting's presentation on Nail It with Nadira. Nadira?
Thank you very much, Paul. Can I screen share? So thank you so much, Paul and CVI, for this great opportunity. And good evening, friends and colleagues. Welcome to the next episode of Nail It with Nadira. My name is Nadira Hamid, and I'm truly blessed to be joined by my esteemed colleagues who are key opinion leaders in the tricuspid space and 3D ICE imaging. And today we'll be talking about 3D navigation for tricuspid transcatheter edge-to-edge repair. And let me tell you, this is really a total game changer for your TEER procedure imaging. And the reason for that is because it really helps improve the workflow process. It's really efficient. And most importantly, it gives me as an imager and my interventionist the confidence and really for the best outcomes possible. So without further ado, these are my disclosures. And so we know that the challenges for tricuspid TEER imaging, you can see on the left-hand side, you have a really dilated right ventricle, you have a horizontal heart, and imaging during the procedure when the patient is on the table can be very challenging. On top of that, the tricuspid valve have multiple segments, as we know, which means that it has multiple coaptation planes, as you appreciate in a transgastric view. And then on the right-hand side, you appreciate that these leaflets are very different from a mitral leaflet. They are what we call fingertips-like. And so we want to try and avoid side biting and really get a good grasp of this leaflet. And 3D ICE technology has really revolutionized of how we image and get back good outcomes in the tricuspid TEER procedure. And so the agenda for today is really reviewing the features of the Verite Pro 3D ICE catheter. We want to discuss the imaging considerations when using 3D ICE. We want to know the nomenclature for 3D ICE manipulation so we speak the same language as us imagers and the interventionists. We want to compare 2D and 3D ICE imaging of the tricuspid valve. And the crux of this whole agenda is really that 3D navigation with 3D ICE for control image optimization, followed by a live simulator demonstration by our very own Lynne Brown from Philips on 3D navigation. And we'll conclude with a clinical case review by Dr. Gagan Singh and Edris Aman. And all of these that we are presenting today in today's webinar has been published in last month's JACC imaging article. And I advocate you to download it and have a read about it at your own leisure. And I really want to thank my co-authors for their support, and really a special shout out to Lynne Brown, Brian Tizer, Raylin, Adam Macy, and the whole team and the entire Abbott and Philips team for their continuous support during this process. And so starting off, your Philips Verite Pro ICE catheter, looking at the diagram here, it has really been on the market since 2021. Now, with the addition of 3D ICE technology, this Verite Pro catheter is really comparable to your TEE ICE transducer as you compare to your 2D ICE catheter. What does this mean? Your 3D applications that you get on your TEE can be used with your 3D ICE. For example, your digital steering, your X-plane support really gives you that high resolution of all your structural procedures, your devices during the procedure, giving you a high precision and confidence. In addition, the 3D ICE, with its close proximity to your tricuspid valve, you are not limited by any confounding factors during the procedures. For example, like you get on TEE, your lipomatous septum, giving you a lot of shadowing, your bioprosthetic aortic or mitral, or even the horizontal heart. So if you look at this diagram, there's three components to the system. On the right-hand side, you have the machine itself with the Epic system, having the appropriate software and hardware and license option, and liaise with your Philips representative for that. Your second is your patient interface module, and that is still your non-sterile portion and is reusable. And last but not least is your Verite Pro catheter, and that is your sterile portion. And what about the ICE catheter itself? So just a quick overview of it. You have a 9 French outer diameter. You have on the right-hand side, bottom right, you have the 4-way steering with a deflection range of 120 degrees in all directions. It is a 90 by 90 field of view with a 4 to 10 megahertz, which gives you a very good penetration and high resolution. And looking at the catheter tip, you have an atraumatic design, really for safety. And you look on the right-hand side, you have a clutch knob at the top of the handle, and this can be partially engaged. So you can add tension to your steering wheels, or you can actually lock it. So you maintain any adjustment that has been made. Now, what are the imaging considerations for 3D ICE? Now, what makes 3D ICE catheter so special, or the imaging itself? So look at on your left-hand side, your 2D ICE catheter. Now, it only uses one line, which means that it only has 64 elements and gives you a very small footprint, and it uses a 9 French catheter. Now, if you compare it to your 3D ICE, so you have a 15 by 56 array, which means that it has a total of 840 elements. The more elements you have, it means you have a higher resolution. Now, not only does it also perform 3D imaging, like what I mentioned earlier, it has a 90 by 90 field of view, and it does have a small footprint as well, using a 9 French outer diameter. So it has a small footprint. Now, if you compare your 3D ICE catheter with your TE, it's similar. And the reason for the similarities is that it has an X matrix imaging core, just like your TE Pro. So think about it of your 3D ICE as a miniaturized version of your TE transducer. The only difference that it has is that the shape of your imaging matrix, as seen in the diagram here. So you look on your left-hand side, your TE transducer, the imaging matrix. It is a square shape, and look on the right-hand side, your 3D ICE, it is a rectangular shape. And what is the difference? The difference is really during the imaging in the terms of the plane orientation between the TE and your 3D ICE. So on the left-hand side on the TE, your 0 degrees angle is horizontal on your TE, but on your 3D ICE catheter, your 0 degrees angle is actually in line with your catheter. So let me explain a little bit more about this. Now, because of this rectangular shape of the array, there's what we call a long and short aperture of the transducer, as you see on the right-hand side. So your 0 degrees plane of the Verite Pro is in line with the catheter and has a long aperture than your 90 degrees. So what does this mean? So if you are at 0 degrees, you have the highest resolution. Now, if you image away from the 0 degrees, you can see that the aperture gets smaller, which means your resolution can be affected by it. So the highest resolution is really between 60 and -60, and on the other end is 120 and -120. So really almost all angle for spatial awareness and the location of device is really important. And really for a more detailed stat for your tricuspid TEER, especially when it comes to leaflet insertion, you want to keep this zone over the area of interest because it gives you your highest resolution. And that's why 3D navigation works. And we will cover this during this presentation and the live demonstration and the clinical case by Gagan and Edris as well, to give you that workflow that you can work efficiently so that you go to the desired location without really resorting to trial and error. But before we go to all of this, really we have to speak about the same language between us imagers and our interventionists, and really and this is the common nomenclature for 3D ICE imaging. So on the left-hand side, you have clock, means turning the handle away from the user, counterclock, turning the handle back towards the user, advancing towards the aorta, pushing the catheter into the sheath, and retracting back is withdrawing or pulling the catheter back out of the sheath. Now, as mentioned earlier about the steering wheels and the four-way direction, so here you can see the catheter can be controlled with the steering wheels, and this is called flex, and this is done in 4 directions. So you have on the left-hand side, right and left, and on the right, on the left is right and left, and then on the right-hand side is anterior and posterior. Now, in addition to these manipulations, we also mentioned about digital steering can be performed, and this is actually performed from your echo machine itself. So this is similar to your TEE omniplane. Your ICE catheter can also rotate 360 degrees, and this is what we call tilt. Now, tilt is what we use in X-plane, and is adjusted by sweeping your M line back and forth across the screen. And in standard X-plane tilt is actually your lateral tilt, and we use it a lot in our TEE, and it's the most common type of tilt. In terms of elevation tilt on the right-hand side, it's been available for a long time. We do use it on our 3D TEE, but not as frequently. But what 3D ICE imaging, it capitalizes on this type of tilt because it really mimics your clocking and counterclocking of your imaging plane without actually having to physically move the catheter. And the best part of it is actually controlled by us imagers at the console. And it's really helped to be very helpful because it helps that minor adjustment to optimize that image and really help relieve the burden of my interventionist, Paul, when it comes to really optimization of the image as well to get that leaflet grabs during a tricuspid TEER therapy. And so these are the common nomenclature that we should really adopt and also use during the case between both the imager and the interventionist as well, and so help in your imaging workflow. And so moving on next is the 2D and 3D ICE imaging of the tricuspid valve. So back to TEE, we know this view, your RV inflow outflow view. This is really equivalent to your bicommissural view for your mitral valve. And this is really important, not only in your pre-procedural planning and intra-procedural as well. As you can see on the top left-hand side, sweeping across from your posterior all the way to your anterior, appreciating on your orthogonal views, the septal leaflet, and seeing where to really grasp as well, both with color and no color. And you can see this is usually found between your 50 to 70 degrees angle on your TEE. And this imaging plane is really angled towards the short axis of your aorta and shows the entire RV inflow and outflow tract all the way to your pulmonary artery. How about in 3D ICE? So 3D ICE, we call it the home view. So this is your typical starting view for ICE, and is obtained by really advancing the ICE catheter into your right ventricle and clocking until your tricuspid valve comes into view. And if you clock a little bit more from your home view, you actually open up your right ventricular outflow tract and other anatomical landmarks, and you appreciate it. The pulmonary artery, you can actually appreciate as well your moderator band and the aortic root as well. And this is called your aorta and pulmonary artery view, which is your AOPA view, and is usually comparable to your TEE RV inflow view. Now, while this is similar, let me show you how to make a very small adjustments to your imaging plane so you can actually get to your true RV inflow outflow view on your 3D ICE. So let's start with your 2D ICE version first. So really it relies on putting the catheter in and clocking towards the aorta until you see your tricuspid valve. Now, as you look at this video, you can see that the catheter is clocked and counterclocked to realign the plane with the aorta. And when this view is revealed, you actually see the traditional version of something of what we call your home view. And this usually has been the standard nomenclature in ICE catheter. And that is because of your limitations of 2D ICE. You don't have that 3D features, and you really rely on manual manipulation of your 2D ICE catheter to get to your home view by entering and just clocking. And so with 3D ICE, what we should be saying is 3D ICE rotated. So you have the ability of 3D, just like in TEE, to rotate the imaging plane towards the aorta instead of just clocking. So you look at this video, it shows you how the plane can be rotated positively or negatively to the desired location. And when you do this, you actually reveal a more open RV inflow-outflow view similar to your TEE, and also a more short axis of your aorta. And so here you can see the angle plane on the left-hand side, your TE, your RV inflow outflow view, and your right-hand side, a 3D image, a 3D ICE image as well, that really obtain that plane that is aligned to your TE. And this gives you that consistency between TE and 3D ICE imaging, which is actually rotating instead of just clocking when you use a 3D ICE catheter. And so let's just review how the 3D ICE catheter orientation over a normal tricuspid valve. So the orientation you see on the left-hand side, your aorta is at 12 o'clock. So this is a normal oriented tricuspid valve. So the aorta is in the surgeon's view at 11 or 12, and the ICE catheter enters into the SVC from the IVC below all the way towards the SVC. So you can see the angle 0 to 90 degrees. And then on the right-hand side, when you click on your console of -45 and 45, and why do we choose this? And that's because you understand, the ICE catheter, that this falls in the highest zone of resolution and really better align in terms of between the commissures of your anterior and your septal leaflets as well. Now, these may not actually be the actual angles, but actually -45 and 45 is a good starting point because you use the best orthogonal angles available to fall into the highest resolution. Now, here you can see if you align the aorta towards the 5 o'clock, for some of us, you can see it's the same thing as well. So you have the IVC on the top left-hand side, the SVC on the bottom right, and here similarly as well, if you want to move the catheter towards the aorta, you would actually push it in. And if you want to look a little bit more separately, you will clock it. And then if you want to go a little bit more lateral, you would just counterclock it as well. So the difference between the previous slide and this slide is just the location of the aorta. Previous slide, the aorta is at 11 o'clock and here is at 5 o'clock. But what is key about all this is that, here you can see this is a simulated tricuspid valve, right? And you align the green plane on the anteroseptal commissures and you can see it's -25 degrees. Now, the good news is that on a normal valve with an IVC, the anteroseptal commissures is usually a negative rotation from 0, so it gives you that grasping view, a more favorable angle actually. But sometimes this may not be the case, so we have to be flexible. Some of these angles are anatomically dependent, and so you may need to actually manually manipulate the catheter or do micro adjustment on the console to get to the best optimization. So it's really dependent on the anatomy of this patient. As we know with the tricuspid valve, these severe TR patients, varying anatomy with different sizes of your right ventricle. And so just to be flexible about that. And so to the crux of this whole agenda and presentation is 3D navigation. So a little history about it. So if you think about it, that 3D imaging is really well established with TE for all our structural procedures. And your 3D images are usually cropped. You use a lot of 3D NPRs in order to get to your desired view or angle. And so you will crop this 3D NPR or a volume, and you are required to actually stay in the 3D to maintain that optimized imaging view. And then you crop into a 3D ICE volume, sometimes does not improve the angle over the desired target, especially when you do the similar steps for TE with ICE catheter. And the only method for ICE catheter to improve that is really to physically move your imaging zone by actually adjusting your catheter itself. And that's why we came up with 3D navigation. It is a different way to use 3D to navigate to your target because you want to ensure the highest resolution over the target anatomy, which is your device. And so once you're there, you can actually switch between 2D and 3D very seamlessly with great visualization and optimization with no trial and error at all. And so for this novel technique, really you have to start with 3D and you use the view lines to guide, and it really takes the guesswork out of optimization. And what's great about it is that it actually puts the control back into the interventionist's hands, which I really know that that is what they absolutely love about that. And so the main uses of 3D navigation with 3D eyes. The first one is really to understand the trajectory of your ICE catheter over your tricuspid valve. And I'll show you a case, an example over the next slide, what I mean about this. How the device enter into right atrium, and it gives you a very good information when you start with the 3D eyes. But the crux of 3D navigation is really manually aligning the planes over the area of interest, which I've mentioned, and Lynne will show you a live simulation of that. So what do I mean by understanding the trajectory of 3D ICE catheter and using 3D navigation? So you can see on the left-hand side here, this was a case example that we had at MHI. And so, we were actually struggling, and this was with my my previous colleague, Richard, as well. So we were struggling to even get a home view, which is very, very uncommon, and took a moment once we entered into 3D to understand where the imaging planes were landing over the valve. And you can see on the left-hand side, as we put to 45 and minus 45, your catheter was actually located on the left-hand side and is actually aiming right at the interatrial septum. And this was very helpful information to know, because then we were able to maneuver around it and get to the precise location. I know if we didn't know this, this would affect the entire procedure and lengthen the procedure time and blindly finding our way. So we adjusted the planes with confidence with 3D navigation and rotated much more positively. And so you see on the right-hand side, once we rotated, you are able then, once you get out of 2D, you can get an anterior septal graph at 130 degrees, which is a non-standard angle, but certainly with clear visualization and with good imaging quality. And so before I wrap up and hand it over to Lynne, so over here is the most important use of the case of 3D navigation. And what I mean is, I mentioned earlier, to manually align your high resolution planes over the device arms, as you can see on the left-hand side, to optimize our grasping view. And this technique is best explained by a visual demonstration. And I'm going to hand it over to my one and only Lynne Brown from Philips, who's giving you a live demo, highlighting the steps, and we will give you all this workflow. And this is PowerPoint slide is the workflow steps for the grasping view. So rest assured that this is available on the JACC imaging paper, the workflow steps. It's also available. We have imaging quick guide. So reach out to your Philips, your Abbott reps as well, who will be able to help you, give you this quick guide, or even reach out to any one of us for further guidance. And so before that, I would like to hand it over to Lynne Brown for the live demonstration.
As Lynne is powering up, I mean, that's clearly a tour de force presentation, really eye-opening what we can see. And well, after Lynne goes, I think it'd be helpful to get some clinical perspectives from the cases and understand just where this really fits in our practice. I think it's been game-changing for us.
Yeah, I think for us too, Paul, we've learned a lot from each other, and we've learned a lot from you guys, and along with Lynne and her team, who've pioneered the training, not just the training, but understanding how the catheter moves. And I think for the folks on the call, as Paul mentioned, this was a tour de force. There's no way that you can listen to this in 1 hour and be masters of 3D ICE. So, I would strongly encourage teams to practice on the simulators, but also practice in cases where you have great visualization. Those are the cases where you work practice as a team, and ultimately then you can pull it in the tough cases, and then you're not trying to figure the system out at that time.
Completely agree. It's best to figure this out in a straightforward case. Not in a hard case.
Agreed.
Agreed. Agreed. All right. Can everyone see my screen and hear me adequately?
Yes.
Great.
Great. So, thank you, Nadira. It's an honor to be here, everyone. I am Lynne Brown from Philips. And, 3D ICE is being used very effectively in TEER procedures, especially for grasping views. Sometimes when the ICE catheter is placed, the views are perfect or ideal, and you need very little manipulation. And sometimes the views needed, as she said, fall into angles that have less than a desirable resolution. So when this happens, we have to move the catheter itself to get these planes in the perfect place. And this optimization, it's a dance between the imager and the interventionalist, and with adjustments needed both on the catheter and on the console. So using our ICE simulator, I'm going to demonstrate how our 3D navigation technique can help really take the guesswork out of this and give you an optimization that's intentional and efficient. So as you can see, I have entered the ICE catheter here into the home view. And actually on this heart in this simulator, even in home view, it's a pretty wide open RV outflow tract. That is not usually the case. That just happens to be the heart in my simulator today. The first thing I want to do is, we're not even going to talk about 2D. We're just going to jump right into 3D NPRs. So when I jump into 3D NPRs, I'm going to pull my volume down. Let's do a little Z rotate. We're going to put the aorta around 11, 12 o'clock. And let's do that also with this one. So what we can see here on the bottom right, and let's enlarge that, is we're at 0 and 90 degrees. So the green line right now is at 0. The red line right now is at 90 degrees. That's how I entered X-plane and NPRs. We can see that our green line is really falling in line with the catheter, or sorry, with the aorta, which is not the usual situation. Usually it's a little to the right of it. But when we think about this, if we're at 0, this green line is where our catheter is sitting over the valve right now. So the bottom of the screen is inferior, the top of the screen is superior. When we're doing valve procedures, we're usually saying posterior and anterior, but lots of different names for the same locations. So if I advance my catheter, we're going to notice that this X is going to go more towards the aorta. When I pull it back, this X will go more towards the IVC. If I clock, I'll move septally. And if I counterclock, I'll move laterally. So as you can see, just by turning on 3D, I immediately know how my planes are sitting over the valve. I can see how my adjustments to the catheter are moving my imaging planes. So I wonder if I can get an anterior septal grasp just by clocking. And on this heart, it's not too bad, but there are a couple other manipulations I could make. So I could also do an anterior flex, which we talked about it. So let's watch what happens. Let's see how the valve moves more anteriorly. And if I do a posterior flex, you can see how it moves more posteriorly. If I do a right flex, let's watch the volume. So I want you to really look at the volume and not the lines. So if I do a right flex, my volume rotates to the right. And if I do a left flex, my volume rotates to the left. Now, initially, it's a rotation, but this is not a true rotation because we are flexing the catheter. So eventually, the planes will move away from the valve if we have too much left and right flex applied. But initially, we can make small adjustments like that. So let's see if I could get on this AS commissure. I think I would like my volume to move. Here we go. To the right, just a hair. I overshot just a bit. All right. So let's get my lines back. So I can see in my green plane up here on the left, I have that kind of home view we had, and then I have a nice potential grasping view here. The key to 3D navigation is we will not move these view lines in NPRs. If we move the view lines, we have to stay in 3D. If we move the planes, we have the ability to go in and out of 3D seamlessly. So I might think to myself, well, this is a pretty nice grasp. I could potentially grasp here. But the problem I'm running into right now is that my red plane is at 90 degrees. And we don't really want to grasp at 90 degrees because we know that's our lowest resolution. So we'll just go back to the beginning for a quick second. I'm going to turn on X plane. And I'm going to change those initial planes to -45 and +45. And I'm not going to adjust anything except move the planes where I need them to go. I'm centered over the valve and I'm going to enter NPRs again. So now, again, I'm going to put my aorta Sorry, hold on. Yeah. I'm going to put my aorta up here at 11 o'clock. And I'll move this one as well. So now I have those two optimal views, -45 and +45, both fall in the good zone. My catheter is still in the same place. It's still inferior superiorly pointed, but now instead of being a cross shape, it's an X shape because my catheter is living right here in the middle. So now we can see that I could possibly move these planes to get a little bit better over that anterior septal commissure. So I'm gonna clock, counterclock, I could advance, I could retract. Now I know not everyone works with their aorta at 11 o'clock. So we're going to do a Z-rotate and put our aorta back down at 5, both sides. And this might be more what you're used to looking at. So catheter is entering from up here on the top left, because all I did was rotate Z. Catheter is in the same place. All we are now doing is looking at this image rotated. Again, if I advance or retract or clock or counterclock, I can adjust these planes. These are the exact same movements the interventionist would use to move the device. If you want to go more septal with your device, you clock. If you want to go more lateral, you counterclock. If you want to go more aortic, you advance. So it's all the same moves. It's very intuitive for what you've already been doing. So I'm going to get my planes back here. I'm going to try to get my green plane on my commissure. And I'm going to try to get my red plane in my grasping view. So you can see how I'm just moving and adjusting over my 3D volume. Now, if you look at the green and the red planes, this red plane is now my grasping view. The beauty of this is now I can return to X plane. I can have the highest quality imaging for that grasping view. And I did it with a very methodical, intentional way of moving the planes without guessing. You know, anything in ultrasound, there are always confounding factors. -45 and +45 might not be the perfect angle. You may still need to adjust a little bit after the fact, but I could always adjust a few degrees, go back into NPRs, recheck, make sure that I'm lined up the way I want to be, and move on from there. Thank you. Just wanted to remind us that, you know, we can use this to confirm how our catheter is sitting there. It's especially helpful in leaflet grasping. And as Dr. Singh said, this does take practice. And we're here to help you in any way we can. Thank you.
Paul, can I comment on something?
Of course. Fantastic.
That was fantastic. And I actually use 3D navigation now to teach our fellows just for like a mitral clip grasp. And I asked them, like, how do you know, before we do the case, you know, they say, well, I think this is 140 and we're over A2P2. I said, how do you know that? They said, well, I think I'm over A2P2 and it's a potential grasp view. And then I put them into, I use 3D navigation, the same technique you do, go into NPR, and I say, that's how you're slicing the valve. So you actually have to be at a lower angle and you'll be at a true A2P2. So I've actually found this technique to be good, not just with 3D ICE, but to like teach fellows how to get perfect grasp views every time, so they can go straight to 142, decrease their sector width, and you get the perfect image Paul likes, which is a high resolution, high frame rate. Gagan likes it too. So you can see the leaflets perfectly. So I really think this concept should be used for a lot of other things too.
100%. I mean, it's just game changing as to basically, as Nadira knows, I insist on 2D images for the finer movements of my catheters, but the 3D really helps you keep from getting lost. So, Nadira, you want to introduce the next speaker? I'm not sure who's going next.
Yes. No,
Go
go
ahead.
ahead, Paul.
No, go ahead.
No, so I think, I think the final segment is really giving you a flavor with a clinical case of 3D navigation. And my pleasure to introduce to Dr. Edris Aman and Dr. Gagan Singh from UC Davis to introduce the case.
Great.
Yeah, go ahead,
Thanks,
Gagan, if you want to.
Nadira, Paul, and the rest of the CVI gang. I think on behalf of Edris and I, we're honored to be here. Edris is going to do most of this since he's the one that drives the imaging console, and I'll just make a couple of brief comments from an interventionalist standpoint and a group that's adopted the 3D ICE. As interventionalists, Paul will attest to this. We have the most patients out of anybody in any procedure room out, right, Paul? So we have tons of patients, and so we exude patients. And so one of the things that's really interesting about the ICE imaging is, unlike TE imaging, Nadira and Edris, you guys have the TE probe and then you're manipulating the console at the same time. Sometimes you're doing one and the other, but you control both. And this is a scenario where the interventionalist is controlling the ICE catheter, but the echocardiologist is controlling the console. So I think it's really important to develop a workflow and a communication. And Edris and I do that in our lab, and we'll say, hey, Edris, okay, I'm going to manipulate the catheter now. So then he stops manipulating the console. And then I'll stop manipulating the ICE catheter, and then he'll go to the console. And we have this kind of communication back and forth. So hopefully you're in a happy relationship in your echo interventional cardiologist relationships, and you guys like talking to each other, but you're absolutely really going to need that here as you communicate the maneuvering. And if not, Paul has counseling that he can set up for groups to help you guys through that. So in any case, this is a recent case that we did. Edris was kind enough to put it together. I'll just introduce it. And then really I'll have, Edris talk about the nuances of the imaging. And he really, has done a phenomenal job helping us develop our tricuspid program, and really is the eyes for what we've been able to accomplish. And I cannot thank our echo partners, not just at UC Davis, but across all throughout the trial and globally, that have helped as implanters help us understand imaging quite a bit. So again, this is an older patient with chronic atrial fibrillation and severe TR. So a common theme in patients that were enrolled in the Triluminate clinical trial. This patient actually, interestingly, had, quantitatively at least moderate mitral regurgitation. And so there was a lot of debate about, do we treat the mitral first or tricuspid? And we can save that for a different day. But for the most part, the TR was out of proportion to the MR, mostly right-sided heart failure symptoms. So that's what we treated with. So the patient went to standard workup, make sure they were on good medical therapy, and all their left-sided disease was well treated before we brought them in for their procedure. So next slide.
Oh, sorry about that, Gagan. There you go.
Yeah. So at this point, I would feel very inadequate to talk about echo imaging. Two phenomenal echo imagers here on the call. So Edris, I'll let you take it away.
No, thanks, Gagan. I love working in lab with you because we talk constantly. And my wife one time saw us talking when we had lunch, and she's like, "You two, it's like your second wife." It was she was a little jealous of you, Gagan. So the left image is just showing you a basic 4-chamber on transesophageal, and you can see the atria, the right and left, are quite large. So this is the typical atrial-induced TR patient that we saw in the Triluminate clinical trial, right? Which is the atrial-induced TR, big RA, planar tricuspid valve. And you can see the RV inflow view, deep esophageal. There you can see the TR location. It's mostly SA and central. So, that location is optimal for TEER. We then did our MPRs. So this is the sequence we usually go through. The left image is 2D, the right is with color, lower frame rates. We really focus on the red plane for our grasp. So here you can kind of see we're cutting this mid SA. You can kind of see it on the 3D rendering quite well on the left image, right lower quadrant. And then you can really see the grasp there. You can see the planarity of actually the tricuspid annulus in the right plane in the left clip. And then you can see when you put color on, you can actually see here this entire annulus, there's just color throughout. You know, there actually is posterior TR that we didn't really appreciate as well when we first went in. So then we actually go and we actually said, well, let's plan this out. So Gagan and I actually do this, you know, Gagan, we really talk out the case well beforehand. And so we said, okay, we're going to put a mid SA clip for sure, but where's the second clip going to go? You know, and I will map out, you know, where there are chords, and there was a large chord in the central SA position. So I said, we're likely going to fall septal posterior. And so this is a potential central septal posterior grasp if we end up falling there. And then we go into our transgastrics, which we feel like is our North Star. This is a complex valve. This is not a 3-leaflet valve. Actually, the anterolateral papillary muscle falls around 8 o'clock in the left image. If you're an imager, you counterclockwise rotate your probe. When you get the transgastric, you end up seeing more. You end up seeing more of the ventricle, and as you clockwise rotate your probe, you end up seeing more of the atria. So it's actually at 8 o'clock. So it's actually a very small anterior leaflet, which is not usual. And there's 2 large posterior leaflets. And there's a prominent cord. It looks like there's 2 septal leaflets, but I believe when we mapped it out, there was a prominent cord there too, right at that central SA position. And you can see the color really well. When we did our 3D VCAs, which you do for every case, it was 4 or 5 plus MR. So then we actually like, when we get transgastric, to also do MPR off this. And I feel like this is the best for mapping out chords. I know this is a 3D navigation talk, and we'll get to it in a second, but I really do believe like this is a phenomenal method to map out chords. You can see a little bit of a septal chord there at the central SA position. We then in the right clip move to the central SP position, and we see like, okay, we have enough leaflet here. Probably could put an XTW there if it's needed for the second clip. So let's go to 3D ICE imaging. So once we did our planning with T, we go to 3D ICE. So we advanced in at 0. And, you know, here we're getting our RV inflow view that Gagan gets. You can kind of see now the TR we initially thought was just SA and central is actually throughout the entire coaptation. And actually the 3D ICE kind of brings it in a little bit better than esophageal. And we usually switch to -45 at this point. Gagan, can you comment maybe on what manipulations you kind of do at this point when you're at -45 to optimize the imaging?
Yeah, I think one of the key things that we've learned is that we always maneuver in 0. So first of all, the one thing that Edris will say, hey, can you, so this is the first time when we're not happy with an image, I'm actually yelling at myself to optimize the image. Usually it's we're asking our imagers to optimize the image. Really, this time it's on us and we're yelling at us. So if you go back to that 0-degree view, Edris, before,
Sure.
you know, basically if this needs to be optimized first before you start trying to change the angles to -45 or +45. And so I think that you know, in this case, if we're looking at the central part of the valve, the ICE catheter is positioned right over the central part of the valve. If we're clinically interested in more of the anterior or aortic or anterior part of the valve, we would advance the ICE catheter in and position that directly below, and then switch to our -45, +45, which has been our default. And as Lynne very nicely showed, gets you pretty close. The -45, Lynne and Nadira showed us, the -45 gets you pretty close to a commissural plane, and then the +45 would be your grasping view.
Yeah, and I really wanted to use this case, Gagan, because it didn't fall into a traditional 3D navigation grasp at 45 degrees. So here's the sequence we used, okay? So the left upper image, we obtained a 3D volume, a 3D zoomed volume at -45, 45. So what we do is we initially will get this left upper image, the first clip. At that point, I'll click multi-view on our panel, and I'll switch to the waterfall layout. So we kind of switch this number 2 clip. And at this point, the 3D volume is not pointed towards us. So I grab the wheel and I move it towards me. And as I do that, now we go to clip 3. In clip 3, you actually can see the aortic valve. You can see the tricuspid valve, I'm sorry. But the aorta is not at 5 o'clock. It's typically at 3 o'clock. So then what we do is we'll Z-rotate, we'll rotate it so the aortic valve is more at 4 or 5 o'clock, similar to a transgastric. And now what we're really looking at is that red plane and green plane, as Lynne showed really clearly. And we're trying to see, how is our 45 minus 45? How are we cutting things? And just as a reminder, our green plane is minus 45, our red plane is 45.
And Edris, if I can comment, this is exactly where you and I would talk, and as Lynne showed, you for the interventionalists in the that are watching, you manipulate the ICE catheter the exact same that you would manipulate the triluminate or the TriClip system. So if you pretend the X is essentially your clip, and if you want the clip to go more septal, you would kind of rotate your guide catheter clockwise. You would rotate the ICE catheter the same way. If the clip is in the center of the valve and you want to go, the crosshairs, you want them to go more towards the SA mid or SA commissural, you would advance the whole stabilizer in, you would advance the ICE catheter in. So Lynne is right. The maneuvering of the ICE catheter mimics the maneuvering of the TriClip system. And you and I would talk out loud as to how we would get the crosshairs there to say if we're looking for SA mid or SA central.
Yeah, and this is a good case, Gagan, where we could, the red plane represents 45. Despite the maneuvering, we really couldn't get to a perfect grasp view for 45. So we decided we're going to utilize tilt elevation and, understand the angles. And we're going to go over that in a second here. So Gagan's manipulating the catheter here, looking at it, just like Lynne showed very beautifully. So let's get to the procedure now. So we like to advance in with NPR. So actually, I'm sorry, the first clip is trajectory. So here we're doing trajectory with NPR. We then will open up our clip arms in clip number 2 here. And as we open up our clip arms, we do our alignment with NPR pretty much every single time now. And then at that point, with the arms open, Gagan said, let's go to 3D ICE now, and let's actually see our alignment. Because when the clips open, we know we're aligned how we want to be using TE, but let's see what 3D ICE shows us too. So here we're at minus 45, 45 in clip 3. And what we do is we take that volume, do the exact same thing we just showed you. And now you can see here on the 3D rendering, I bolded the green and red plane representing 45, green plane representing minus 45. And you can see our clip alignment. And so we tried to manipulate the catheter as best we could, but we could not get that red plane perfectly parallel to the clip. But what you do realize is if this represents minus 45 and 45, what you'll also learn is that this is 0 degrees here, which means that your clip is probably not plus 45, probably be like plus 70, and you probably would just be parallel to your clip if you get to plus 70, plus 65, maybe even plus 75. So that's a technique that we will often use is we look at the 3D rendering, we look at the lines, and then we can see our clip and we know, hey, this is the angle that's optimal. Hopefully it's in like the go zone of, 60 or minus 60 or 45, 45. Sometimes it falls outside, but those images are still quite good. And this is a really good example that you can be outside 60 sometimes and the images are very good. And here's an example of it. So we went to 70 and what we utilized was the tilt elevation technique. So I really, really, really believe in this because if your X is not exactly at the clip, but 70 is the grasp angle, you can utilize tilt elevation and just sweep into the clip. And that's what we do here is I sweep into the clip and Gagan then checks the grippers. He checks the gripper for the septal leaflet and one for the anterior leaflet as well. So I really, really believe this is a really fundamental, logical method. You can use this beautiful method to sort of get to your grasp view without guessing. And I think that's the beauty of 3D navigation. So now we're advancing in an X-plane, and we love to grasp with transgastric. I know everyone doesn't like that, but we love transgastric, as Gagan knows. So we're in transgastric in image 2, and in image 1 here, we've actually grasped, or I'm sorry, image 3. And as we grasp, the arrow is pointing out the anterior leaflet, because the anterior leaflet has way too much mobility, and it is not falling into the middle of the clip. So if you read a lot of the papers from Europe, they've really published really early on about transgastric grasping, the importance of it, and this is one that probably is not optimal. So what did we do? Well, we utilized 3D ICE because 3D ICE is phenomenal for grasping. And as you see, we're utilizing tilt elevation again. So we're going to start here at 70 degrees, and the arrow in clip 1 is pointing out that anterior leaflet. It is very mobile. It looks like it has way too much movement. It's falling low. It's not optimal. So we opened up our arms. You can see right there, and then Gagan optimized in image 3 so we can get more leaflet in there. And Gagan, you love transgastric grasping. That's just one of the thing that we love in our lab. You know, you can comment on it. I love it too, actually. I've fallen in love with it.
Yeah,
Paul, well,
I,
I think,
yeah. Oh,
you know,
sorry, go ahead.
no, I say Paul, we too, right, Paul? We, use it a lot, in terms of the grasping and confirmation of that.
Yeah, I think the transgastric is really best for your coaptation planes. Like I say often, it's the imaging view that doesn't lie. If you're not perpendicular, transgastric is going to tell you, unlike any other view.
Yeah.
Yeah, when
So
you have, go ahead, Gagan.
no, I was just going to say that this is a great example of how and why ICE fits in your workflow. Is that, there's normally what we used to do is you'd start off mid-esophagus, and then you couldn't really see leaflet insertion. You weren't happy with it. Then you would go transgastric. You couldn't really see leaflet insertion, and then you would go back to mid-esophagus, and then you couldn't really see what you're doing. Then you would go back to transgastric. You couldn't really see the leaflet insertion. Then you would go back to and so you just kept going back and forth, and 20 minutes go by, and in our world it's 20 minutes. So it was probably really only 5 minutes, but it felt like 20 minutes, and we hadn't made a decision. So what's nice with this is that it's the same machine as your X8 probe. You don't have to switch monitors. You simply just toggle ICE. So we go mid-esophagus, we grab in transgastric, and if there's any question or we want to confirm, we immediately switch to ICE. The ICE is already parked there, and we just go back and forth, and it really improves efficiency of doing these TEER procedures. I think it really has helped us from that standpoint.
Can I just ask about the tilt angle? How do you know which way to go? Are you just trial and error? Because here's like -3. I saw it was 5 a minute ago, or 2.
So, Paul, what I noticed, and Gagan knows this, those 1 or 2 degrees on that tilt elevation make a huge difference. And Gagan, you've seen this because you work with other imagers in our group who use tilt elevation with ICE.
Oh.
And so I sometimes will check, because my worry is if the catheter moved at all in any way, then it's going to be a little bit different. So you'll see it's -3, then -5, because nothing ever stays still. And even 1 degree makes a difference, or 2 degrees is what I've noticed.
Well, I'm just looking at this picture here. You've only gone 3,
Yeah.
and it's completely different.
Yeah, exactly. Yeah, I totally agree with you. And
So
so
it is a little in terms of, because right now it moves with a trackball, right, Edris and Nadira,
yes.
and I think that one of the feedbacks that we've had for Philips is to try to put this on a dial, so you can easily go from -3 to -4 to -5, because it does with the trackball. It can go from -3 to 10 in like a quick second, and sometimes it's just a matter of 1 or 2 degrees to see something like that.
I would recommend no coffee before a tilt elevation.
Yeah.
So the arrow on clip 2 here. Oh, who was saying something?
No, sorry, Edris, but I really like the comment by Gagan where, going up and down the mid-esophageal and transgastric. And that's where I hate to say this, but really your esophageal injuries. And so what we do, really improving their workflow, you park your TEE in your transgastric view, and then you can switch to ICE. So just literally, so you less manipulation on the esophagus. That's what I found it was really, really helpful when you have your ICE catheter there. So I just park my TEE probe in the transgastric and then just flip back and forth with your 3D ICE.
Yeah, absolutely. I mean, the less probe manipulation, the less risk of GI bleed, which is one of the main things that we worry about as imagers with tricuspid cases. So clip 2 here is just showing the anterior leaflet now falling into the center of the clip, which is really what you want to see in transgastric. So now I'm going to move quickly, given time. We put a central SP clip, XTW there. We grasped transgastrically. It was quite nice, in all honesty. We couldn't go more SA. There was a big cord there that kind of pushed us towards central SP, but we took it because the grasp was just so nice. And we confirmed our grasp again. And this is another feature of 3D ICE people should be aware of. Same thing with TE, which is you don't always have to be 90 degrees off each other. It's not always -45, 45. You can make that right image whatever angle you feel like. So you can just change that omniplane to whatever you feel like. And so we were at -45, 45, and I just changed it to 70 to actually see our grasp view a little bit better.
But to Lynn's point, you do it methodically with a 3D navigation, and it's not just a bunch of trial and error stuff. And I think that's where the concept described by Nadira and Lynne and you, Edris, has really, I think, resonated with myself in terms of using it methodically.
No, I'll be honest, Gagan, I use this when we're doing a pre-tricuspid TEER case. You'll ask me, I'll tell you, hey, there's a grasp view for this mid-SA. And you'll say, how do you know? I'm like, well, I use 3D navigation when I was in mid-esophageal. And I know that if I go to 162, that'll probably be our grasp view. And I can get that because then I'll show you. So you can actually use this technique for other things, which has been very helpful for teaching fellows.
I
So-
tell you that this in the tricuspid space, because of the multiple coaptation planes, the need for this is magnified, because the planes are just all over the place. And depending on the trajectory of the IVC and where it's located in terms of offset, it's this 3D nav is just so important.
Yeah. This is the end now. So here's 3D ICE pre-post. You can see the marked reduction in TR we have with our 2 clips. And here it is with T for pre-post. You can kind of see we markedly reduced the TR, and our mean gradient was only 1. And that's it.
Nadira, you want to wrap it up?
No, go ahead, Paul. Why don't you wrap?
Well, I mean, that was fantastic. You've turned into your images. You're like a cartoon now.
I'm so sorry. I'm not sure what happened. I thought it was me. My phone. I have no idea. I tried stopping a video. Sorry about that, guys.
No. It's no. I
think
mean,
it's the background that from CBI. But sorry about that.
As much ICE experience I think I learned a lot tonight. That was just absolutely incredible, and just reviewing the basics of the 45-45 and the steering capability and such. Lynne, are we going to be able to ever turn our catheter all the way to get 0 all the way on its side? Is that ever going to happen?
You mean to flex it to get 0 on
Yeah,
its side?
flex
Well,
it.
it could do that. Usually the issue is the space in the right atrium and the device being in the way, but it has the ability to turn that far. So
I don't think I have had much luck getting it over there in that direction.
the problem is when you flex is you move away from the valve. You don't rotate. And that's why 3D is so important, because it allows you to rotate. So the combination of flex and rotation is really what does the trick.
Hey, Paul, can I, in the final 3 minutes, can I ask a kind of an open question, just maybe to foster some discussion? Kind of a 10,000-foot view on 3D ICE and where it fits in tricuspid TEER. Why? I mean, I want to congratulate you on this very well-attended seminar of all the people who logged in, and I guess why, for early adopters, why in your experience, why has 3D ICE been useful? What has it helped kind of your practice, and how should kind of these early adopters or these new adopters, how should they kind of approach 3D ICE and tricuspid TEER?
Well, it's what it's helped us with is the real importance of leaflet insertion confirmation. I think with tricuspid, if you look at, for instance, the SLDA rates, why in expert hands do we have SLDA rates of 7 to 8% in tricuspid, when long ago we figured out how to reduce SLDA in mitral from 8 to 1%. So why would an expert mitral operator have an SLDA rate of 1, but then when he does tricuspid, he or she does tricuspid, it's 7? And I actually think part of that is that we're still learning about leaflet insertion and being oriented to coaptation planes. And to me, that's been the biggest learning part about doing tricuspid procedures with the Verite device, is it really gives an added confirmation of leaflet insertion. And so to me, this 3D steering gets you there. Because you have to put the crystals where you want to image, and before it was just kind of steering around, and I would say I don't want to say I was making it up, but yeah, I was kind of making it up. It's just we have to be humble here. We were learning, right? And so that's my perspective. I don't know, Nadira. I mean, you've seen the experience and the value.
Yeah, no, I absolutely agree. When we first started using the 3D ICE, remember, Paul, it was like what Gagan said, the communication. And that's when we set out, Idris and Gagan, the whole group, all of us, to put our heads together. We got to come up with a better way, a more effective way for 3D ICE manipulation. And thanks to Philips and Abbott as well support, and we came up with this 3D navigation. And so right now, I mean, all the cases that we did, right, Paul? Certainly once we put the ICE catheter, okay, we got into the home view. The first thing I say, okay, Paul, I'm going to 3D nav. No messing around, going to your 3D nav. He waits for me and just literally, and then once he see that 3D, that catheter, I said, okay, you know what to do. And then he just maneuvers to that desired location, highest resolution, and you can actually see it in your multi-view views, that clip arms coming in plane. I say, okay, I think we're there. Okay, and I switch back to 2D. There you are. With confidence, precision, and just a smooth workflow right now, Paul. And it's, really efficient in terms of clip.
It allows that 2D optimization, which is committal in my view, in my opinion. I think 3D is it certainly gets you in the ballpark, and that's what 3D navigation steering do, but it allows that 2D optimization. So how about you, Gagan, Edris?
Yeah,
What do you guys
I think in addition to helping us with substantially reducing SLDA rates, which is going to be important from an outcome standpoint, but also case efficiency. We have no problem trying to do 3 or 4 tricuspid cases in a day, because we know that we have this, and now actually Edris himself will ask for it. He'll try to look for leaflet insertion transgastric, and if you can't see it, he goes, okay, just go ahead and take the ISAC catheter out. And so we've now just improved our operational efficiency. It's streamlined. We're all speaking the same language, and again, the SLDA rates have really dropped anecdotally, obviously, but we'll have to see how the data shows. But I think from those 2 key 10,000-foot view, that's kind of the real why behind this. It's yet another adjunctive modality to help improve outcomes and efficiency.
Yeah, I agree. I see it as an adjunct, which is when you have phenomenal TE imaging, maybe you necessarily don't need it, the 3D ICE catheter, but when you need it, you need it. So you have to practice using it on easy cases. So you have to have a good TE imaging case. You practice your 3D ICE catheter, get your reps in to develop that muscle. And then when it's needed, it helps you treat someone who you otherwise couldn't have treated. And it helps you release that clip with confidence, which is makes me more relaxed in the lab, at least.
Well, we made it through almost 4 years of putting patients in Eliminate without doing any ICE. And then now with it commercially available, I can't live without it. So it's one of these things that sometimes we don't know. And the more I use it, the more I love it. So it's what it is. But I think we're past the hour. Actually close.
No,
Go ahead. Go ahead. Yes, please.
I was going to say, and there's other structural heart cases where there's uses for it that you didn't really think about using it, and all of a sudden you're like, wait a minute, I could potentially use this for this other thing that I had difficulty with TE visualization. So it's just I think it's a great thing to have in our toolbox.
Fantastic. Well, we're past the hour. I want to thank you all for participating, especially my great faculty. And Lynne, welcome. This has just been fantastic. I love listening to you present and describe the techniques, and that was an amazing case and Nadira's tour de force introduction. So thank you all, and please again consider coming to CVI in July, and hope to see you all there. And thank you for being with us tonight. Good night, everyone.
Thank you. Good night.